Hello, I'm Rachel Deere, host of today's program, COVID-19, Keeping Up with the Moving Target. This is the June 26th update of DKB Med Radio's Coronavirus Educational Series. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AMA PRA Category 1 credits. Please visit our website for complete CME and CE information. To attest for CME and CE credit, please visit covid19.dkbmed.com. There, you will find all of our previous COVID-19 programs and have access to other free CME and CE programs on a wide range of topics. The slides for today's webinar and previous webinars can be found under the Resource tab. Today's learning objectives are: describe the disparities in COVID-19 population, discuss COVID-19 trends found in the Black and Latinx populations, and discuss strategies to mitigate and eliminate risks and disparities in these populations. This activity is supported by an educational grant from Pfizer Incorporated and in kind by DKB Med. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters, and are free of influence from Pfizer Incorporated. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He will be interviewing Dr. Kathleen Page, an Assistant Professor in the Division of Infectious Diseases at Johns Hopkins School of Medicine. She will be discussing disparities and their impact on COVID-19 in the Latinx community. Dr. Auwaerter, Dr. Page, thank you for being here today.
Yeah, thank you, Rachel. And it's just delightful that Dr. Kathleen Page is joining us today to center on, I think, some highly important issues that we're really still learning so much about with COVID-19. You know, in the first 6 months, I have to say, initially we sort of knew from the Chinese experience that people of older ages and comorbidities really presented, significant risk factors for being hospitalized or unfortunately dying. But especially as we've gotten more information from Europe and North America, it's become apparent, especially here in the United States, that Blacks, for example, members of the Latinx community, and Native Americans have really had a greater tendency towards more severe disease, hospitalizations, and so on. Everyone sort of looks for issues, genetics, is it socioeconomic? And Kathleen, I know you've been here at Johns Hopkins with me for quite a while here, and Baltimore is a city that has a significant Black population, but a growing Latinx population as well. Tell me a little bit your views about what might be socioeconomic issues and barriers to healthcare versus maybe something that's a little more intrinsic or related to comorbidities. What's your view?
Yeah, I think, Paul, as you've mentioned, it certainly has emerged not only in Baltimore, but throughout the country, that health disparities, racial and ethnic health disparities associated with COVID-19, with Blacks, Latinx, and Native Americans having higher rates and also higher morbidity, hospitalizations, and deaths. So I think there's a number of factors, I would say structural factors, that are contributing to this. I would say a lot of this, frankly, when you see patients that are mostly impacted, what's notable to me is that so many of them are from fairly low socioeconomic status. Many of them, because of that, are having issues with access to healthcare, issues with employment, living in essential, working in essential jobs that don't often afford the protections needed. And many of these are people who were working right at the peak of the pandemic. And then because of low socioeconomic status, housing conditions can be such that can really contribute to transmission. So lots of people living in crowded settings. Here in Baltimore, what's really been really remarkable has been, and something that I've been very involved in, has been the impact, particularly among Spanish-speaking Latinos. And, as you know, Paul, I've been working with this community for over a decade, and certainly had been aware of many of the factors that are challenging when it comes to healthcare. For example, many of these patients, if not a majority of the Spanish-speaking Latinos in Baltimore, are not eligible for health insurance or the Affordable Care Act exchanges. And so there's a large proportion that are uninsured. And while there are FQHCs and clinics that will accept these patients and take care of them, many of them have not actually been able to engage for a variety of reasons. In addition, these patients, these people, not all of them are patients, are not eligible for other benefits, including, for example, unemployment benefits, the stimulus check. And so there's a real necessity to continue to work. And so it's really been almost a consistent story in many of the patients that I've seen, that they were working. When they developed symptoms, they felt like they had to continue to work because that was the only way to make money and to survive because of low savings and other issues. And then again, because of their low wages, many are living in very crowded conditions that I don't think I was even aware of until this happened. For example, 10 laborers who are not necessarily related, all living in a 2-bedroom apartment and sharing a bathroom, or families that are sharing a townhouse. So the townhouse may have 5 bedrooms and there's one family of 4 or 5 in each townhouse. And as you can imagine, with COVID-19, that is a real recipe for transmission.
Yeah, you bring up so many important points, and I think it's so hard to know, because I think there's just multiple issues that unfortunately are just conspiring to make these very hardworking and family-oriented people, especially ones that are so dependent on paychecks, to move ahead. I've heard a number of things just as I've been assisting with COVID care since March, and just was wondering your impressions, because on the one hand, some issues speak to people that just haven't gotten a lot of routine care, undertreated or non-treated diabetes, for example, or perhaps people that have higher body mass index and obesity as a risk factor. And then, on the other hand, it's, is it more people that tend to live in large population, in larger homes and facilitate spread, super spreads? We have the meat packing plants as a kind of work issue. And then lastly, I even wonder about public health messaging, how receptive, how good are we doing trying to help message on a public health standpoint here, because unfortunately many people in these jobs don't have employers that are organized or have the will really to help inform and take care of their workers. I think it's really difficult on so many levels, I think. But is there any sense you feel what contributes more or less? It may be so hard to say.
I think these are really such critical questions. Let me sort of unpack it piece by piece.
Yeah, please.
The issue of comorbidities or underlying comorbidities, I think, contributes. I don't think it's the main driver. It certainly contributes to severe disease, as we all know. And so obesity, but in particular diabetes, has really jumped out to me. And as you know, Paul, we've been doing some consults. We've set up this consult service at Hopkins to deploy bilingual providers to help the teams and the patients. And one of the things that has really stood out to me is how many people are coming in with diabetes and a hemoglobin A1C that's high, to suggest that this has been ongoing for some time. But when you talk to them, they had never seen a doctor since being in the US. And so I actually had someone look into this a little bit in our system. And among those, just to give you a sense, and this is sort of very first pass information, data, not fully whatever, but among those patients who were Latino who had a hemoglobin A1C and were admitted into the hospital, not all of them had one, but among those that did, only 10% had a normal hemoglobin A1C, about 30% had prediabetes, and the rest had diabetes, and among those, over 50% had an A1C of over 9, which suggests to you either poorly controlled or not diagnosed diabetes. And this is consistent actually with national data. Last year, there was a publication in JAMA looking at undiagnosed diabetes by race and ethnicity and prevalence of diabetes. The diabetes among Latinos was the highest from any other racial ethnic group at around 22%. It varied a little bit by country of origin, and I think there's some genetics associated with that. With the highest rate among Mexican Americans, it was about 24%. And concerningly, and I think relevant to this conversation, Latinos also had the highest rates of undiagnosed diabetes, more than twice as high as whites and other groups. Yeah. So I think that certainly is contributing, and certainly contributing to the severe disease that we're seeing.
And so many, as you point out, are afraid to access medical care because of engagement with the system that has often created issues about documentation issues and so on, or it could be on a cost basis without any insurance. So, and I it's interesting because I think many don't know about, for example, federal healthcare centers, or still leery about seeking help there.
Yeah, and frankly, at least in Baltimore, I've been in contact with these centers, and they're also at capacity. So their ability to take more patients is also somewhat limited. I think, you asked me about public health messaging, and I think that is actually really critical. And while there's been sort of generic messaging, and most of that messaging is translated to Spanish, and that's definitely a good step. Well, first of all, let me just say that there's been mixed messaging from public health all along the way, not necessarily because—
It could be in English too.
Yes, exactly. As we learn things, messaging changed, right? So there was messaging about not using masks, and then to use masks. And then, and then there was early on, if you remember, Paul, there was, because of limited testing ability and PPE, there was a pretty strong message to stay home if you had symptoms and call your doctor. And that, raised red flags for me, because I knew that, that's a good advice for me because I have a doctor. But I knew that so many people in this community did not have a doctor. And so they were probably hearing the message, stay home, and then I don't know what to do with that. So we did set up very early on a bilingual hotline with our partners, Esperanza Center, a community-based organization. And in that line, I am so thankful to them that they were willing to deploy that quickly, because it got over 1,000 calls early on, and the positivity rate among people who were calling that line was over 50%. So there was a huge demand. There were other lines that were set up by both Hopkins and the health department. The problem with those lines is that they didn't have Spanish speaking capacity. And so then it becomes a huge barrier, right? It's hard to call a line if you don't talk the language. So there was a little bit of mixed messaging, but I would say that, one of the most important messages that I think this community specifically needs to hear, and it's very helpful if it comes from public health or institutions like Hopkins, are two big messages. You should seek help. It does not matter if you have insurance or papers. There is help, and you will sort of, something to the aim, you will not get saddled with huge medical bills that will make you bankrupt. So that, I think, is important. And then the other piece is really related to immigration. So many people, because they are here without legal status, they just assume that they're not eligible for anything, because they generally are not. And but that not anything includes going to the emergency room. And so having some measures that says, really, healthcare systems, public health, we do not collaborate with immigration authorities. It is safe to come here, and we welcome you. We want to help. I think those to me would be the two key messages. Like, right now, worry about your health, not the money. We'll figure it out. And secondly, we do not collaborate with immigration authorities.
Yeah. Hey, Kathleen, I think those two messages are just so important, for at least practitioners and patients to understand and help work with what other institutions or public health officials in the community. I mean, you've done such fantastic and innovative work, especially with the Latino community, but really it's a model, I think. And you talk about what I might call lost in translation in a bit, because you're very medically oriented with your juntos and working with Esperanza and so on. There's a little story that I think you may have heard, I'm not sure, but it really helped one of our patients tremendously that I think sort of captures a lot of these threads. So one of our inpatients was Spanish speaking only, hospitalized with severe COVID, but had improved enough to be discharged, but still required oxygen. And in Baltimore, we've turned the convention center, our convention center, into a field hospital. So people didn't have resources, they don't have insurance, they can get oxygen and sort of lower acuity care there and so on. And of course, we had a medical translator from a service, work with our house staff and our attendings in translation, but the patient was adamant. He did not want to go at all, absolutely adamant. And we couldn't understand why. And so, he was taking up a hospital bed and so on. But then your group came in and quickly determined that whatever the medical translator was translating, the convention center to this patient meant detention center. And you were able to clarify that this had nothing to do with immigration services or anything like that. And I think we would have just been flummoxed otherwise. And so it's those kind of aspects that are really just so valuable, that you need to know the community and their concerns. And even a Spanish translator didn't really have enough depth to try to understand.
Yeah. So, I actually was a person who saw that patient.
Oh, good. So would you.
I remember him very clearly because he was one of our first initial consults. And, I had to say, this is a young man. I walked in the room, he was petrified. And one of the things that, as you said, the juntos consults, which is again bilingual providers who get deployed to help the teams, we are medical providers and really are, that's what we want to talk. We want to talk medicine in Spanish directly to the patient without third-party interpretation. But a lot of the conversation ends up being just shooting the breeze, because it's so, as people, practitioners know, these poor COVID patients, English or Spanish speakers, it doesn't matter. They're very isolated in their rooms. Nobody shows up except essentially. And so they usually brighten up when someone walks in and starts talking to them in Spanish. They're especially surprised when I talk Spanish because my name is English, etc. They don't think that I will speak Spanish. But I think what I have found in these consults, and he was a classic example. This kid, I say, because he was probably in his 20s, he was young, petrified. And I am 100% sure that the interpreter had said convention center. But to someone who's thinking so much about family separation, detention, and all that, you can see how easily that was he heard something else. And it was easy to explain to him, no. But I of course knew that many people think that. And I've had also the experience now the Baltimore City Health Department has a beautiful 5-star hotel that has been reimagined for isolation for people who need this space. And, in conversations with them, talking to them about how for some people it was impossible to isolate, they said, okay, send us your patients. And that conversation also, although there's no confusion with detention center, what there is mistrust, right? So it sounds too good to be true when we tell people, you can go to this hotel, you'll get 3 meals, we have Spanish language. They just honestly takes a bit of time to convince them that this is true, because for so long, whatever's been offered to them has not been a 5-star hotel or anything close to that. It's just hard to imagine. But I think the key thing is that, when you go and talk to someone in the same language, I find that people ask a lot more questions that maybe they wouldn't have with an interpreter, because it's just a little bit more stunted, the conversation. And so you can have, again, when the things that we do in English as well, giving pause, using silence to get people to open up, asking open-ended questions, that's a lot easier to do in the same language than it is, if you're using an interpreter, where probably yes, no questions are the easier way to do that.
Yeah, yeah. And I have to say, this example to me, whether we're talking about underrepresented minorities or really our whole kind of approach to COVID in the United States, I just think is emblematic that you have trust and you have communication. And when you don't have proper messages, or even with changes, but when you have so many different people saying different things, or there's not the trust component, it's very difficult, I think. And I remember this story that I talked about on one of our videos earlier, but public relations people went through the countries and said which countries had the best messaging, and it equaled the best trust. And who was it? New Zealand. Well, where is there no COVID cases right now? Now, granted, there are islands, but it's New Zealand. Or it's certain countries in Europe, for example, where there's a strong message and good communication skills. And I think what you're speaking here is a community that is so much worse off than many others in the United States, and we're not starting at a great point either.
Yeah, I mean, I think, the communication, if you think about what the community, I mean, you give examples of countries where their big leaders have been very clear in their communication. And if you think about the communication that this community has gotten, including from our highest leaders, it does not encourage trust. Let's put it that way.
Well, Kathleen, Dr. Page, I want to really so much thank you for this great discussion about some of these issues. And I think we're going to have another piece that will focus on some other aspects as well. So wanted to absolutely thank you for your time today.
No, you're very welcome. Thank you, Paul, for having me, and Rachel. Really a pleasure to be part of this conversation.
Thank you, Dr. Page and Dr. Auwaerter, for an enlightening discussion about a very important topic. As a reminder, to claim CME or CE credit, please complete the evaluation at covid19.dkbmed.com and select today's activity. You'll receive your certificate immediately after. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer, at dkbmed.com. Don't forget to access our resource center at covid19.dkbmed.com. You'll find a range of information, including the latest COVID-19 data and statistics, medical society guidelines, and resources in Spanish. Again, thanks for joining us, and thank you for your dedication to your patients with COVID-19.